Imagine a kid, just literally bouncing off the walls, like completely unable to sit still in their chair. And the doctor's gold standard treatment is to hand them a really powerful Schedule II stimulant.
Right. Which sounds totally counterintuitive.
Exactly. I mean, it sounds like throwing gasoline on a fire,
All
right?
right.
But in pediatric mental health, everything you think you know about how the brain works just gets turned completely upside down.
Yeah, we expect medical diagnoses to be super straightforward, like an adult presents with a set of symptoms and we just categorize it.
Right. Box A or box B.
Exactly. But the pediatric brain is this constantly moving target. We're looking at a diagnostic landscape that is driven by, rapidly shifting developmental stages, not just these static symptoms.
Well, welcome to the deep dive. Today, our mission is exploring the incredibly complex, often really misunderstood nuances of pediatric mental health.
It's such a massive topic.
It really is. We're pulling from a super comprehensive pediatric nursing module today. So whether you are a BSN nursing student prepping for clinicals, and you really need to master the components of a mental health assessment, or you're just someone who wants to understand how a child's brain processes stress, illness, and, well, just the chaotic world around them, you are in the right place.
And the data we have sets the stakes for this discussion immediately. I mean, 1 in 5 adolescents currently has a diagnosable mental health disorder.
1 in 5, that's huge.
It's staggering. And yet, an enormous percentage of them are either totally undiagnosed or they are just languishing on these seemingly endless wait lists to even see a pediatric specialist.
Right.
So to understand how we assess and treat this population, there is this foundational rule we have to establish right out of the gate. The etiology, like the root cause of mental illness in kids, is multifactorial.
So it's never just one thing.
Exactly. You're looking at genetics, the environment, and neurochemistry. But the presentation of the illness, how it actually looks on the outside, is entirely dictated by the child's developmental maturity.
So let's look at how that developmental presentation actually plays out in practice. Because I feel like before we dive into the really complex disorders, we have to understand the baseline of how kids process pressure.
Yeah, that makes sense.
Because when a child's developing brain encounters stress, they usually lack the cognitive vocabulary to articulate what is happening to them. They're like pressure cookers without a steam valve.
That's a great way to put it. They do not possess the abstract thinking required to sit down and say, I'm experiencing existential dread.
Right, a 7-year-old isn't saying that.
Exactly. Or I'm having severe anxiety over a family disruption or this bullying at school. Now, the module does point out that low levels of stress are actually beneficial.
Oh, really?
Yeah. A child needs to encounter minor, manageable stressors to build a neurological framework for coping, like learning how to handle losing a game or forgetting a homework assignment.
Okay, that makes sense. Building resilience.
Right. But chronic, high stress like severe, ongoing bullying, which keeps their cortisol levels constantly elevated, that completely overloads that developing framework.
And because that psychological pressure can't be expressed verbally, I mean, it has to escape physically somehow, the psychological distress gets converted into somatic symptoms.
Yes, somatization is huge in pediatrics.
So a child might come to the school nurse's office every single day with severe nausea or a headache or unexplained abdominal pain, or even present with new onset bedwetting.
Exactly, because the child's nervous system is essentially bypassing the language centers of the brain. It takes that distress signal and just routes it directly to the gut or the autonomic nervous system.
Wow.
And you have to remember, the pain they are feeling is entirely real to them. They aren't faking it. It's real pain, but the root cause is emotional.
Which puts the medical provider in a really tough spot, right?
Yeah.
I mean, if you're assessing a kid with chronic stomach aches,
Yeah.
how do we know if it's medical or mental? You can't just assume it's a gastrointestinal issue, but you also shouldn't immediately slap a psychiatric label on it.
Right. And that is exactly why the clinical assessment is so critical. It requires a modified mental status examination that really leans heavily on observation and pattern recognition.
Pattern recognition, like what kind of patterns?
Well, you have to trace the timeline. Does the stomach pain correlate with a specific class? Does it happen right after lunch when, maybe bullying might be occurring on the playground?
I see.
You have to map the physical symptom directly to the social and environmental triggers.
And tracing those environmental triggers often leads us straight back to the child's foundational safety net, which is their caregivers.
Always. It almost always comes back to attachment.
Right. So if that foundational bond is disrupted, that stress manifests as an attachment disorder. And the sources break this down in such an interesting way. Normal attachment isn't just a warm, fuzzy, emotional bond.
No, not at all. It is a hardwired physiological cycle.
Right. An infant expresses a need by crying. The caregiver meets that need by feeding or holding them. And repeating that tiny cycle thousands and thousands of times literally wires the infant's brain to perceive the world as a safe, predictable place.
So when that cycle is broken, whether through neglect, absence, or severe trauma, the developing brain shifts into a constant, unending state of threat assessment.
Just constantly scanning for danger.
Exactly. And the texts note this can result in a child completely failing to thrive or withdrawing entirely from human connection.
Or they can swing the total opposite way.
Right. Their nervous system might just hyperactivate, leading to severe separation anxiety. And we aren't talking about typical, first day of school jitters here.
Right, a little crying at drop-off is normal.
This is extreme physiological panic every single day for an entire school year. It persists well beyond normal developmental stages.
Well, the module introduces this super profound concept to explain how deeply these early disruptions embed themselves. It's called the primal wound theory. It's a heady concept.
It really is. The primal wound theory proposes that if an infant is separated from their mother at birth, maybe due to a prolonged NICU stay or maternal loss or severe addiction, they suffer a devastating sense of losing a literal part of themselves.
Because biologically, infants perceive themselves and their mother as a single continuous organism, which is just wild to think about.
It is. Their nervous system hasn't yet differentiated its own survival from the mother's physical presence.
Right, so a separation isn't processed as an emotional loss. Because they don't have emotions like that yet, it registers in the primitive brain as a literal physiological amputation, like, where did the rest of my body go?
Exactly. The baseline circuitry for safety is wired improperly from day one.
That's fascinating, but intense. So if the brain is wired to feel like it's missing a vital limb, that kind of trauma wouldn't just fade away simply because the infant doesn't have conscious memories of it yet. Does the source say how long that trauma can last?
The source material confirms it alters their baseline sense of safety for years. It makes it incredibly hard to overcome. Because treating a disruption that deep requires completely rewiring their perception of safety from the ground up.
So how do you even begin to do that clinically? It seems like you'd have to find one completely reliable anchor to rebuild that biological cycle from scratch.
That is exactly the core of the clinical intervention for attachment disorders. You identify one emotionally available attachment figure.
Okay.
And crucially, the treatment involves deliberately limiting the child's contact with other non-caregiving adults during the initial stages.
Which feels a little mean at first glance, right? Like you're isolating them. But it makes sense when you consider the threat of non-discriminant attachment.
Absolutely. If you flood a traumatized child with multiple supportive adults, a brain that is that desperate for a safety signal might just latch on to anyone.
They might seek comfort from literal strangers, just trying to find that biological regulation.
Right, which puts them in highly dangerous situations. They have to learn that safety comes from a specific, consistent source before they can trust the wider world.
Okay, so if attachment isn't the root issue, moving away from those external bonds, we have to look at what happens when the struggle is driven deeply inward by neurochemical and genetic factors.
Yes, transitioning into mood and anxiety disorders.
Right, and pediatric depression affects about 5% of U.S. children. But assessing it requires looking completely past adult symptoms. A depressed kid isn't necessarily just sitting in their room crying.
No, often they act out or they just completely shut down. The module uses the sad faces mnemonic for nursing assessments, which is really helpful.
Yeah, sad faces, sleep disturbances, anhedonia, despair, fatigue, appetite changes, concentration problems, emotional sensitivity, and suicidal ideation.
Exactly. But what's so vital there is understanding the neurobiology behind it. Take anhedonia, for example.
The A in the mnemonic.
Right. It's the complete neurological inability to feel pleasure. If you have a kid who just lived and breathed baseball, and suddenly their brain registers absolutely zero joy from it, that's not just a moody behavioral phase.
Right. They aren't just being difficult.
Their dopamine reward pathways are fundamentally blunted.
And assessing those shifts is so critical, especially because the S stands for suicidal ideation. Pediatric providers must constantly assess risk for suicide.
Always. You are looking for sudden changes in behavior, giving away possessions.
Or even a sudden, unexplained sense of calm, right? I read that in the source.
Yeah.
That can indicate the child has actually made a firm decision to end their life, so the turmoil is gone.
Yes, that sudden calm is a massive red flag that is so often misinterpreted as the child getting better. But while depression carries severe life-threatening risks, anxiety is actually the most common pediatric psychiatric disorder.
The most common.
Yeah.
And the nursing interventions for severe anxiety, they really highlight how heavily a child's nervous system relies on its environment for regulation.
Oh, entirely. If a child is panicking, adult panic is highly contagious to them.
Right, so if you freak out, they freak out harder.
Exactly. So the clinical intervention is to immediately decrease room stimuli. You dim the lights, you silence the clinical monitors if you're in a hospital setting, and the provider must remain visibly, intentionally calm.
You are essentially offering your own regulated nervous system for the child to mirror.
The clinical term for that is co-regulation. The child's autonomic nervous system is frantically searching the room for cues.
It's like radar.
Right. And if the nurse or parent's tone is slow, steady, and grounded, the child's heart rate and breathing will subconsciously begin to sync with that baseline.
That dynamic gets really fascinating when we look at obsessive-compulsive disorder, which is rooted in severe anxiety. OCD involves obsessions, which are the intrusive, terrifying thoughts, and compulsions, which are the repetitive behaviors.
Yes.
And there's this really counterintuitive nursing intervention from the source. It says that if a kid is performing a repetitive ritual like tapping a desk a specific number of times, you absolutely do not interrupt the ritual. Why is that? Our instinct is to stop them.
I know, it feels so wrong to just let it happen. But to the outside observer, the tapping looks like the problem. To the child's brain, however, that compulsion is the only available pressure valve to reduce an overwhelming physiological spike of internal panic.
So if you physically or verbally interrupt the tapping, you trap that pressure inside them. Their anxiety just skyrockets.
It skyrockets. And worse, you'd be reinforcing their brain's misguided belief that the ritual was the only thing keeping them alive.
Because you stopped it, and they felt like they were going to die.
Exactly. So if you can't stop the compulsion in the moment, you have to rewind the tape and catch the thought before the compulsion even starts.
Is that where the therapy comes in?
Yes. Therapists utilize a technique called thought stopping for exactly this reason. They train the child to recognize the physiological onset of the obsessive thought.
Like the tightening in their chest or their pulse racing?
Right, and they teach them to mentally halt the cycle right at that trigger. You dismantle the root mechanism rather than just fighting the outward symptom.
Okay, so we just mapped out how anxiety and depression pull a child's distress inward. But what happens when neurochemistry pushes that distress outward?
Externalizing disorders.
Right, disrupting the classroom, the home, and societal norms. That brings us back to the paradox we opened the show with, ADHD.
Attention deficit hyperactivity disorder. It's characterized by inattention, hyperactivity, and impulsivity. But a really crucial diagnostic detail for assessments is that a child can be predominantly inattentive without the physical hyperactivity.
So they just appear constantly forgetful, losing homework, staring out the window.
Exactly. But for the kids who are hyperactive, the ones who literally cannot sit still in their chair, the gold standard treatment involves central nervous system stimulants.
Medications like Adderall, Vizance, or methylphenidate. Let's dive into the mechanism of why giving a hyper kid a stimulant isn't throwing gasoline on a fire. Because I think a lot of people struggle with that logic.
It really comes down to dopamine availability in the frontal lobe. The frontal lobe is the brain's executive functioning center. It is responsible for planning, filtering out distractions, impulse control.
It's the brain's manager.
Right. In an ADHD brain, this frontal lobe is chronically understimulated. So the child is hyperactive because their brain is desperately seeking external stimulation to wake that executive center up.
Oh, wow. They're essentially self-medicating their understimulated brain through constant physical movement.
Precisely. So when you introduce a prescribed stimulant, you artificially increase the dopamine levels in that specific area.
And that wakes up the frontal lobe, allowing the executive function to finally kick in, filter out the noise, and control the impulses.
Exactly. The stimulant reduces the physical hyperactivity by giving the brain the chemical baseline it was craving all along.
That makes perfect sense when you break it down like that. But obviously, there are still strong medications.
Right, which is why providers must monitor closely for side effects like weight loss and insomnia, because it is still a systemic stimulant affecting the body's metabolism and sleep cycles, even if it has a calming effect on behavior.
So ADHD is disruptive, but it's a neurochemical, mechanical issue. The module also covers externalizing disorders that involve deliberate defiance, which is a whole different ballgame.
Yes. Oppositional defiant disorder, or ODD, and conduct disorder.
And the dividing line between ODD and conduct disorder is incredibly stark. It hinges entirely on the development of empathy and remorse.
It does. With ODD, a child displays a persistent pattern of anger and disobedience toward authority. They might yell at a teacher, or refuse to do tasks, or even throw a chair.
But once the autonomic arousal comes down, once they cool off, they feel actual remorse. They have an intact moral compass. They just struggle massively to regulate their emotional reactions in the moment.
Right. Conduct disorder, however, is a very different clinical entity. It involves severe, deliberate violations of societal norms and the basic rights of others.
We're talking destruction of property, physical aggression, real cruelty.
Yes, and the defining characteristic is a profound lack of empathy. They do not feel remorse for the harm they cause, which makes conduct disorder a massive clinical red flag.
Because left untreated, the text says it is a direct precursor to antisocial personality disorder in adulthood.
Exactly. It's on a spectrum of serious pathology.
The module also points out a very specific clinical warning sign in older children, known as the MacDonald Triad.
Yes, this is a really important cluster for assessments.
It's a cluster of 3 behaviors: bedwetting past an appropriate developmental age, cruelty to animals, and pyromania. Now, when you first look at those 3 things, they seem entirely unrelated. Why would setting fires and bedwetting cluster together with animal cruelty?
It's a manifestation of profound internal tension combined with that undeveloped empathy center we just talked about. Bedwetting often points to deep, unresolved physiological stress or severe hidden trauma in the home.
Okay, so a huge stress indicator.
Right. Then, cruelty to animals allows a child who feels entirely powerless in their own life to exert absolute control over a weaker subject. And they can do it without the barrier of empathy stopping them.
And then pyromania, setting fires. The text mentions that provides an intense sensory release for that built-up internal tension.
Exactly. When these 3 present together, it is a glaring indicator that the child's psychological development has derailed significantly. It requires immediate, intensive intervention.
Okay, so we've discussed behaviors driven by understimulated dopamine centers and undeveloped empathy. Let's look at what happens when the brain's fundamental wiring for perceiving the world is completely altered.
Right. Moving into the neurodevelopmental spectrum, particularly autism spectrum disorder.
And the clinical urgency here is really driven by the data. I mean, ASD diagnoses are growing at a staggering rate of 10 to 17% per year.
It is the fastest growing pediatric disability,
Right.
which makes early screening an absolute priority for pediatric nurses and providers.
And this screening is typically done between 18 and 36 months using the MCHAT, right?
Oh.
The modified checklist for autism and toddlers.
Yes. And it's important to note that MCHAT isn't just looking for bad behavior, it's tracking specific delayed developmental milestones in communication and social reciprocity.
Like if a child isn't talking by age 1, or if they don't respond to their name. I read that sometimes parents genuinely suspect their toddler might be deaf, even though their physical hearing is totally perfect.
Exactly. Those are major neurological indicators. Other early signs include poor eye contact, hand flapping, or obsessively aligning objects in really rigid rows.
Why the rows? What does that do for them?
The child's brain is attempting to impose predictable order on a world that feels overwhelmingly chaotic to them.
Ah, I see.
And this need for order is deeply tied to sensory processing disorder, which very frequently runs alongside autism.
With sensory processing disorder, the nervous system completely misinterprets sensory input, right? Stimuli that a neurotypical brain just filters out automatically, like the hum of a refrigerator or the brightness of a fluorescent light or just the chatter in a classroom.
Right. Those things register as intense, unignorable signals. The neurological filtering mechanism is impaired.
This brings up a really relatable, specific detail from the text. If you've ever watched a child have a massive, screaming meltdown over putting on a pair of socks, your initial instinct might be to think they're just throwing a tantrum, just being stubborn.
Most people do think that.
But if you look at the sensory processing data, the texture of that sock seam isn't just mildly annoying to them. Their brain misinterprets the tactile input as physically harsh, even painful.
Yes. The neural pathways transmit the sensation of a cotton seam with the same urgency and severity as touching a hot stove.
Oh, wow, so it literally hurts.
It does. And this is why nursing and therapeutic interventions emphasize that you cannot just force a child with a highly sensitive nervous system to tough it out. The therapeutic milieu, the environment itself, must be adapted to the child.
So you have to decrease the stimuli. You provide seamless clothing, you dim the lights, and offer a highly structured, predictable routine.
Exactly. It requires a complete paradigm shift in how we view the child's behavior. Early interventions like speech therapy, play therapy, and occupational therapy, they aren't about curing the child's perception.
Right, because you can't cure how their brain is wired.
Right. They are about giving the child tools to navigate a world that, frankly, wasn't built for their sensory needs, and doing it early enough to improve their lifelong trajectory.
It requires providers and parents alike to look past the surface behavior. You have to look past the meltdown, the defiance, the physical complaint, and really interrogate the underlying mechanism. The breadth of pediatric mental health is just staggering. I mean, we started with the biological roots of attachment and how a primal wound alters a baby's fundamental survival circuitry.
We unpacked the mechanical anxiety reduction of an OCD ritual.
Right. We explored why stimulants actually calm a hyperactive brain and realized that a simple pair of socks can cause legitimate neurological overload. It's just so much.
It is. And if we connect all of this back to the bigger picture, it leaves us with an incredibly important consideration about how our entire society operates.
Consider the data we opened with. 1 in 5 adolescents has a diagnosable disorder. Autism rates are climbing up to 17% a year. ADHD is incredibly prevalent. This raises a really profound question.
It does. Are our societal structures, like traditional, loud, highly stimulating classrooms where kids are expected to sit perfectly still for 8 hours, actually becoming fundamentally incompatible with the modern pediatric brain?
That is such a heavy thought. We place so much emphasis on diagnosing the child.
Right. But given the sheer volume of children struggling to adapt, perhaps we need to start diagnosing our environments as well.
Wow. It brings us right back to our original point. Pediatric mental health isn't a clean, easily visible break on an X-ray. It's a complex, interconnected web of neurochemistry, development, and environment.
Absolutely.
Understanding the specific mechanisms of that web is the only way to actually help these kids. It's something for you to think about the next time you see a child acting out in public or struggling in a classroom. There is always a neurological why beneath the behavior.
Always.
Thank you for joining us on this deep dive into the source material. We hope it gave you some powerful new lenses to view the world through. See you next time.